Hello, everyone, and welcome.
Did we lose Tara? What happened?
I think she's still here.
I thought it was just me, so
Yeah,
I
it
was not aware.
disappeared. Now we're back. Now we're
Okay.
back. Okay, I will start the recording. Oh, it's already recording. So welcome everyone to our town hall meeting. I will start by giving the mic and the camera to Dr. Alibhai to start our town hall today.
Okay, well, good morning, everyone. I hope you're all doing well. It's nice to feel warmer weather and still seeing all this snow around us. And thank you to Prevention of Blindness and Tara for organizing this. I would like to introduce you all to Dr. Peyam Mojallal. He's an optometrist. He does low vision, just like I do, and he actually sees patients once a week, correct, so far, in Alexandria only. So I'll just let him introduce himself and tell you a little bit about himself, and then we can get started with the rest of the talk. Dr. Mojallal, please.
Hi, everyone. I hope you're all doing well. I'm Dr. Peyam Mojallal, and I will be, I am actually currently doing low vision over at Alexandria. I have over 20 years of experience in the optometric field and a lot of years doing also low vision. I am one of the assessors for DBVI, Department of Blind and Visually Impaired, and I've been seeing low vision patients now for a number of years, and I truly enjoy it, and I find it to be very rewarding. Um, and I'm more than happy to meet those of you who I haven't met yet.
Well, thank you. Thank you very much, Dr. Mojallal. And it's really great to have a colleague doing low vision with me now, because as many of the people on the call know now that they've been all saying to me for a long time, you need to get some help. You can't just keep doing everything by yourself, and my schedule keeps getting more and more backlogged. So it's really wonderful to have you on board, and we're very happy and very grateful that you have joined on and decided to do this.
Thank you.
So, what we're going to do today is talk a little bit about low vision, a little bit about things we can do to help people, and of course, take your questions, because I know every time we do these town hall meetings, we talk, and then there's never enough time for questions, and then, you know, you always feel like, I wish we had a little bit longer, and we only have an hour today, so I want to make sure that we do get to your questions. I'll begin by just letting everybody know that my own practice now has merged with the Prevention of Blindness Society. So for many of you are my patients and have been with me for a while, you know that I was running my own practice, Low Vision Services PLC, but I was using the space provided through the Prevention of Blindness Society. So they have a office in, or a building in Washington, D.C., which is the headquarter office. It's very close to Union Station. It's just been renovated, and I really do encourage you all to one day come by and take a look at the facilities. I think we can arrange with Tara a good time when maybe we can give tours and show people around and show you how the building itself has been modified for lighting and contrast to accommodate people who are visually impaired. So I do see patients there. There's a building that the Prevention of Blindness owns in Old Town Alexandria, where Dr. Mojallal and I see patients, and I'm here today. And Here it's a much smaller setup, even though it's still a big building, but it's a much smaller space that's being used for the low vision part of this thing. And I was seeing patients in Maryland, and that office in Bethesda was part of Colonial Opticians. But unfortunately, there was a fire soon after Thanksgiving in that space. And because of that fire, that office, that Colonial Optician space in Bethesda will no longer be accessible or available. In fact, Colonial Opticians are going to try and consolidate the optical part of that office with their other location, which is in Rockville, Maryland. So for those of you who are on this call from Maryland wondering, well, when is Dr. Alibhai going to be back in Bethesda? I'm probably not going to be back in Bethesda. But once this consolidation occurs and Colonial Opticians Rockville have expanded their space and been able to now replace all the equipment that was burnt and damaged, and it all has to be replaced now, and the insurance companies are working on all that. Then, God willing, I will be in Rockville, and so it'll be a Maryland location as well. Now, it'll all still be under the Prevention of Blindness Society. So from now on, appointments to see me or Dr. Mojallal are done through the Prevention of Blindness Society, the 202-234-1010 number. And the appointments are scheduled through the Prevention of Blindness Society. Right now, like I said, I'm only seeing patients in Alexandria and in DC. A lot of the Maryland patients have had to come to DC, unfortunately, and I feel bad. I know for many of you, transportation is the difficult part. And certainly there's no good parking around DC. I park at Union Station sometimes myself even. But it's a short walk from Union Station, and if you are using Metro and you're comfortable making the short trek from Union Station to the Prevention of Blindness's headquarter building, it's just literally a block away. So it's an easy walk, and there's a sidewalk. So for those of you who think that you can switch your appointment from the Maryland location to DC, then I'm happy to see you there. But I don't anticipate being in Maryland probably till summer. I don't know. I'm guessing. I hope it's sooner, but looking at what it takes to replace things and build out things, it may be a while. So that's just some information for you to keep in mind. Okay, so let's jump into this field of low vision and rehabilitation and what Dr. Mojallal and I do, and we'll kind of tag team it. I'll cue Dr. Mojallal when he can also give you some insights and information. So the first question, of course, is, what is low vision and who qualifies to be seen for low vision evaluation? And we define low vision as any vision which, even after getting glasses or contact lenses or whatever you have, still cannot be improved to normal. And of course, normal for everybody is, can I have perfect 20/20 vision? But I'd like you to not think of vision so much now in terms of numbers, but in terms of function. And that's what we deal with in the low vision field. We're dealing with how well can you see to read? How well can you see to drive? How well can you see to use your computer? How well can you see to navigate and ambulate, walk around safely? Or how well can you see to use your computer or whatever it might be? So it's really based on function. A lot of times people come for low vision and they say, I just want to get the low vision glasses that restores my vision back to 20/20 or normal. And of course, that's not what we're going to be able to do. This isn't something that there are special low vision glasses. They look like ordinary glasses. You put them on and everything is normal and you see normal again. That isn't quite how this works. We are using visual aids, tools, strategies to overcome your visual deficits. And that's how this whole process of vision rehabilitation works. So, Dr. Mojallal, who would you say are the more typical patients we see with low vision? What kinds of diagnoses and issues do you find they're coming in with?
I mean, I find that a lot of my patients tend to be people with diabetic retinopathy, advanced glaucoma, and macular degeneration. Tend to be kind of the big threes that I see.
That's right. And most of the times we're recommending that patients be referred for low vision rehabilitation. So you should be having a conversation with your doctor, your specialist. Your, like Dr. Mojallal says, is if you have diabetic retinopathy, you're going to be seeing a retina specialist. And that person should be saying, yes, it's a good idea. You should go get a low vision evaluation. Or if you have glaucoma, you're seeing a glaucoma specialist, or a general ophthalmologist can be treating you for glaucoma as well, then you should go see a low vision specialist and see if they can help you. And of course, I find the majority of my patients have macular degeneration, and that again is something not curable, but there is treatment. So you're getting treatments for the dry type, the wet type, and your retina specialist can again say to you, yes, please go and see a low vision specialist and see what they can do to help you with your vision. And we do prefer that you're referred by your specialist, and we usually request that your specialist send us just the last chart note. You know, sometimes we request records and we get a big thick pile, but that's not what we're looking for. We're just looking for, you know, the last note, which sort of says what treatment was done and what your vision was like and what they're going to be doing. And that's where we sort of begin this whole process. So, Dr. Mojallal, a lot of patients say to me, well, I think my problem is cataracts, you know, and what about cataract surgery and how does that fit into having low vision?
Well, certainly, I mean, if you have like patients that have cataracts, in addition to, let's say, something like macular degeneration, that can compound the effects of the decrease in vision. So if the health allows, and if the surgeon feels that they're a good candidate as far as the health of the eyes, I think that having cataract surgery would definitely benefit someone who does have low vision as a result of macular degeneration or anything else, because you're just removing one of the obstacles.
That's right. And, oftentimes patients will say to me, Dr. Majalan, that I had a friend who had cataract surgery and now he or she doesn't need glasses and they see perfectly. How come I had cataract surgery, I have macular degeneration, glaucoma, whatever, but even after cataract surgery, I'm not getting that wow effect that my friend got from having that surgery.
Yeah, I think it's very important to kind of set our expectations, set realistic expectations, prior to doing any kind of cataract surgery, because you're absolutely right. Someone who doesn't have anything going on with their retina or the rest of the health of their eyes, having had cataract surgery, they're going to get much better vision than if you have someone who has some diabetic retinopathy or some macular degeneration. Um, we can't expect to have the same outcome. So I think it's very important that we go into any kind of surgery with kind of a clear understanding of what our expectations would be.
Right, right. You've got to have realistic expectations that the cataract surgery fixes the lens part of the eye, the focusing part of the eye, if you like, but um, it doesn't fix the macular degeneration part of the eye or the glaucoma part of the eye, the diabetic retinopathy part of the eye. So, yes, it might be useful and helpful to have cataract surgery, And like Dr. Mojallal said, it's one less obstacle that the light has to then deal with. The cataract is an opacity, so light has to travel through that. So that's one less obstacle to deal with. But then it doesn't restore the macular degeneration, and it doesn't fix the glaucoma, but at least hopefully things are a little bit brighter and maybe in a little bit better focus, which is why it's useful to still have cataract surgery done.
And if I
So the
may
next,
add to that, Dr.
yes,
Alibhai, sometimes it's actually much easier for the retinal specialist to kind of monitor what's going on in the back of the eye as far as the macular degeneration, because if they're having to look through a dense cataract, much like you're having to look through a dense cataract, their view is going to be obstructed too.
makes sense, makes sense. Shannon, I see you got your hand up. You got a quick question?
I do have a very quick question. A
Mhm.
lot of times, I've heard for myself or other people that the cataract needs to ripen. Is there like a time frame with that, or what exactly does ripen mean? If that can be answered in a quick question.
Sure, sure. That's a good question. Dr. Mojallal, I'll let you take that one.
So basically, we when we say ripen, we need the cataract to get to a certain extent where the deficit or the impact that it's placing upon your vision kind of warrants the surgery. And so we look for very specific changes in visual acuity and also decrease in contrast sensitivity and also like an increase in effects of glare. And so once those requirements are satisfied, then we say that the cataract has ripened and is ready to be removed.
Yeah, that's right. And so it's always a good idea to have that discussion with your cataract surgeon. And usually the cataract surgeon will always say, well, you have macular degeneration, you have glaucoma or whatever. It would be a good idea to get the blessings of your glaucoma specialist or your retina specialist before we do cataract surgery. So, we work as a team in this vision field, and everybody concurs and says, yes, I think it's a good idea, then fine, you can go ahead and have your cataracts done. Um, so it's usually a teamwork approach.
Thank
So,
you.
no, thank you, Kishana. It was a good question. So then what happens when you come and see us and, everybody says, well, I've heard about strong glasses because I've gone to the drugstore and I found that they have up to power three, right? People say I've seen 152, or three. Um, isn't there anything stronger than that? And so the answer is yes, there is, but there are some drawbacks, right, Dr. Mojallal? I mean, we can keep
Absolutely.
giving people stronger glasses, but then you take it from here, you know what the issues are, right?
Yeah, absolutely. I mean, the for just a kind of a quick scenario, the higher the power you go, the more magnification you get, but you also have to hold it closer to you. And so sometimes that's uncomfortable or not possible for someone who has limited use of their hands, or if there's a little bit of a shaky hand, that makes it very difficult. In addition, when you increase the magnification, the higher the magnification you have, the less of a field of view you have. And so now you go from, for example, seeing words to seeing individual letters. And then now you have to put those letters together to form the word. And, it just makes reading more difficult or slower. So just going up in power isn't necessarily the answer. You kind of have to find that sweet spot where the power and the magnification and the working distance all kind of work to improve quality of life.
Yeah, I agree, and it's true. Oftentimes patients are frustrated because they say, well, can you not make the glasses just a little bit stronger? And I'll go, oh, sure. How about I increase it to 4 or 5? And they'll go, okay, great. And they're expecting to hold things out further. And I go, well, no, it's the opposite. Instead of holding things at 12 or 16 inches, you're now going to have to hold things at 4 inches. And they go, oh my gosh, who's going to read like this? I always say to my patients sometimes, when you smell it, you'll be able to see it. And they go, what do you mean when I smell it? I said, well, you have to hold it closer to smell it, right? Well, when you smell the paper, then you might be able to read the paper. And so it's not always, the best uh, acceptance for a strategy like that. So it's going to take more than just glasses sometimes. So we start looking at other options as well. And so now we get into magnifiers, Dr. Mojallal. But of course, what I would like ideally is a magnifier the size of a page, and it can magnify at least 10 times, right? So
Right.
is that going to be possible?
I wish.
That's right. So the limitations with the magnifiers are, as they get stronger, the amount you see is getting smaller and smaller, right? But I do have people, Dr. Mojallal, say to me, I saw on Amazon that they have this big page magnifier, and it looks like it should be able to do everything, and it's big, it has a light in it. What's your impression of some of those things, those big page magnifiers with a light in it that oftentimes people find on Amazon and online?
So I found that some of those, the optics are not as good. They introduce some distortions uh, because, a lot of times when you're using a large magnifier, you have to create the magnification a different way. And it's not like the standard handheld magnifiers, which have kind of a more smooth surface. And but those larger magnifiers actually can degrade a little bit of the contrast and the quality of the image.
Exactly. And that's such a good point that you're making, Dr. Majal, that in our field, we know it's not just making things big enough that's going to be good enough. We need magnification, we need contrast, and we need light. I mean, those are the three things that we use the most in helping people with low vision. The ideal tool combines lighting, contrast, and magnification. So for those people who say, okay, I'm willing to wear the strong glasses and hold things up close when I need to read, you're still going to have to get the light in between you and the glasses. And that's another limitation. And for those people who say, I'm just going to hold a magnifier, I often say, well, it should be a magnifier with a light in it, because the light itself is going to make it easier for you to see. And then there's the contrast effect. And there's no simple contrast strategy. And oftentimes we use digital magnifiers to create more contrast. So Dr. Majal, you may want to touch on the video magnifiers and their reverse polarity capability and things like that.
Yeah, so some of the digital magnifiers out there have the ability to show you the kind of the native or the natural image, but they also give you the option of changing the polarity or the print. So rather than being black print on white paper, it's actually white print on black paper, which that really tends to help a lot of people by improving the contrast. There's also other options that, for example, like blue and yellow combination. Um, and the other thing that I like about the digital magnifiers is that it does allow you to magnify the image with less loss of field for a given magnification. So, like if you were to use kind of a traditional magnifier and do a 10x, you're going to see a smaller field than if you were to use a digital. And with the digital, it also gives you the ability to kind of create a larger, um, a large, to have a larger screen. And so that same 10x could be displayed over a larger area than you would get with a traditional magnifier.
That's right. So that's certainly the advantage of using digital or video magnifiers. And I think most of you have seen these if you've visited the Low Vision Resource Center. As you know, part of prevention of blindnesses programs include this Low Vision Resource Center, which currently is available in all three locations. So in Bethesda, almost the same place where the fire occurred, but upstairs on the second floor, there's a Low Vision Resource Center there. In Alexandria, where I am here, it's on days when I'm not here. So I'm here Tuesdays and Wednesdays. We don't hold a Low Vision Resource Center here. But on other days, like I think it's Mondays, you can meet with Rachel or Anne or Edelyn, and they're here. I know Tara's in DC on Fridays, Tara? Is that when
Some
you're
Fridays and all Thursdays in Bethesda.
all Thursdays in Bethesda? Okay. And when do we hold the Low Vision Resource Center in DC?
DC, it's Fridays.
Just Fridays. Gotcha.
Yes.
Okay.
For now.
Yeah. And so there's a separate number, and Tara can give you all that information that you call to make an appointment to visit the Low Vision Resource Centers. There's no doctor associated with those days, and there's no insurance associated with those days. So that's the other advantage of going to Low Vision Resource Centers. And Tara, Edelyn, and Rachel can show you the visual aids, the digital magnifiers, the different types of handheld and optical systems that are easily used without needing to be necessarily prescribed. Let's put it that way. So for many of you who are waiting for appointments, and again, I apologize that it does take a while to get an appointment, but for many of you waiting, can make an appointment with the Low Vision Resource Center and at least learn about some of these tools and strategies. You don't necessarily need to say, well, this is it, this is what I'm going to use, but at least you become familiarized with some of these so that when you come for your appointment, we can then guide you better and say, you know, for your needs, maybe this is the better route to take. For your needs, maybe this is a better strategy for you. So do take advantage of the Low Vision Resource Center as well. So Dr. Mojallal, the other thing I find people often talk to me a lot about, ask me a lot about, is the glare, you know, that I'm getting a lot of glare, and I'm not sure about, you know, what should I do for lighting and how shall I deal with this glare. So you can have glare outside when you're walking around, or you can have glare indoors because of the type of lighting. So some thoughts on that, Dr. Mojallal.
Sure. So I kind of approach glare twofold. So I'm looking at the what's producing the glare, and so I will have a conversation with patients regarding, you know, how their environment is set up. Where are the light sources in relationship to where they're sitting? The kind of the general rule of thumb I like to use is if the light source is directly in front of you and you're looking at something that's more likely to produce glare. And so I like to have them have the light source more on the side and kind of towards behind them. Obviously, we don't want to cast a shadow, but having it there helps reduce some of the glare bouncing off of the surface. Then the other way that I approach it is using tints. So using tints and polarization. Another way to think of polarization is like blinds, and it allows us to kind of cut out certain stray light by using polarization in the glasses, and that also helps reduce glare, in addition to the various tints that we can use for both indoors and outdoors.
And we have a question in the chat, which I think is appropriate to answer right now. Joyce, thank you. Does TV and regular computer produce glare that is counterproductive to the eyes? Well, no doubt. Both the TV and the computer and our gadgets produce a glare. There's light coming out of them. And counterproductive in the sense that it's not harmful. I think many people worry about that, right, Dr. Mojallal? They think
Absolutely.
that the light coming out of a TV screen, the blue light, or the light coming out of the computer is going to somehow damage their eyes or harm their eyes. It's not so much that, but it is a distraction, and it is something that can become annoying, especially if you have low vision. So we're telling patients, for example, turn up the brightness, right? I'm often telling patients to see your computer better, to see your phone better. You may have to turn up the brightness a little bit more. But as you turn up the brightness, then we've turned up the glare too. So after a while of staring at the computer and it's really bright, or your phone is really bright, and you look away and you go, oh my gosh, wow, my eyes feel like, they've been really, they're washed out almost. So any thoughts, Dr. Mojallal, how do you typically counsel patients on this balance between, yes, you need more brightness, but how would you deal with the glare from the screens?
Sure. So, obviously you want to increase the brightness as you mentioned, but you kind of want to balance it with how much glare it's producing. So you kind of want to gradually increase till you get to that sweet spot where you're getting, much better vision without a reduction from the glare. The other thing that I do want to mention too, as it relates to glare and to computer screens, is that we do have a tendency to blink less when we're looking at a computer screen. And so while as we blink less, we also produce more dryness, and kind of destabilize our tear film. And so that in itself can make looking at screens more uncomfortable, in addition to increasing the glare. So one of the things that I recommend to patients is to kind of have a bottle of artificial tears next to their screen, and you can't use it too much. And so anytime you see it and your eyes feel a little uncomfortable, feel free to put a drop in and kind of get into that habit of using the artificial tears while they're looking at the screen to kind of also help mitigate some of that glare effect.
Good point, Dr. Majalal. And remember, even people with normal vision, people who don't have low
Yeah.
vision, complain of fatigue and glare and issues, dry eyes, like Dr. Majalal said. Um, and we all have to take care of this. Sometimes putting the devices under reverse polarity, right? Putting
Mhm.
white letters on a black background. So most of the screen is dark, and if you're looking at text, that works. You have slightly less glare because you have the inverse polarity. On on the TV screen itself, a little bit trickier because you you're not going to reverse the polarity on the TV screen. Otherwise, everything looks like it's in the negative. But you can try and turn the brightness down a little bit, and don't sit in a totally dark room when you're watching TV. Try to have indirect lighting in the room so it's not causing a shadow or distracting from the TV, but there is some light at least in the room. You're not in total darkness, because you remember how it's like when we've gone to the movie theaters, we're sitting in the dark, movie's over, we go outside, and it's a shock to the system and takes you a while to get readjusted. So um, those are a little bit of tips. I know there's another question from Joyce about what tint color, whether you're getting meta glasses or any glasses. And Dr. Majid, I don't know about you, but for me personally, I tell patients that the color that they're going to pick is really so subjective. It isn't that we say, oh, you have macular degeneration, well, you should pick this color, or you have
Right.
glaucoma, you should pick this color. I don't know what are your thoughts on picking the tint color.
No, I agree with you, and I think it's nice that we have a lot of different colors and samples available to us. And, I utilize that a lot in clinic to just kind of demonstrate. And, sometimes I think, oh, this color is definitely going to work for this patient. And I try it, and sure enough, it doesn't. And they pick something completely different than what I thought, because you're absolutely right. It is subjective, and it's really a matter of trying it out and seeing which one really gives the best results.
That comes up a lot. And I often tell people that, yes, there are some colors that may heighten contrast, maybe like yellow. And, people who hunt or people who shoot have always used yellow to make their target stand out better. And I have some low vision patients who do wear the yellow and find it's helping with the edge of steps and curves, for example. So that's good. You mentioned the polarization, Dr. Mojallal, where we're talking about light that reflects off a surface into one's eyes. And that glare, reflected glare, is ameliorated by using polarized sunglasses. And again, the color can be different colors, but the polarization can be in there. So no matter what the tint is, no matter what the color is, you still have the benefit of reflected light. And I find that's more people who are out on the water a lot, who may have a boat or something, and go out in the water, reflect the light from water surfaces, or people who are still driving and it's rained and there's water on the road and the reflection from the sun from that. Those are the places where the polarization, I find, is really beneficial. The colors themselves, gray would probably be the ideal color, because when you look through a gray tint, the world still maintains the correct colors. So reds look red, blues look blues, greens look green. But if you wear a yellow lens, then everything is tinted yellow. So for some people, even though you might get a contrast enhancement, um, the the color distortion, if you like, is really kind of annoying, because now everything looks yellow. So I think it really is a trial and error thing, and we try to keep different filters in the office, and you can just try them and see what tint, what color works for you, and then how dark you want it. You can always have the opticians lessen the amount of tint so it doesn't feel as dark, right? So that's always worth keeping in mind. Now, there's another question. I'm finding more issues photosensitive at the resource center. Try out sunglasses, usually polarization. So at the resource center, yes, there are some sunglasses, and the thing we don't have, and I think a lot of you are asking this question, so I'm going to try and answer this. There isn't a comprehensive set of colors and tints that you can try everything that's out there. It just, I don't know whether that exists. What we try to do is to show you what's commercially available off the shelf. So manufacturers like Cocoons and Solar Shields make wraparounds, and a lot of opticians will have them in their offices. And so you just go and try them on and see what you think. Now, if you need them to be more refined, there is a website. It's called NOIR Noir, NOIR Insight, INSIGHT, where they have a lot more colors and tints. And you could then refine it further. You could say, I like yellow, but not this darker yellow. I want a lighter yellow. But it's difficult to say there's one place you can go to, they have everything, and you'll get exactly the right color. It would be nice, in the machines we have where we go, which is better, 102, 102. If we had all the colors in there and we would go, which is better, 102, 102, and then you'd say, perfect, this is it, and we'd write the prescription for it. That doesn't exist. That would be great if that ever existed. But anyway, so that's that. Nick Ferrano has put a message question here. can you provide a high-level explanation of what vision rehab is? I've never heard of it before, and I'm unsure if I would benefit. Okay. Dr. Mojallal, you want to try that? What an explanation of vision rehab is?
Um, well, to me, what it means is kind of twofold, because you can kind of look at it from the standpoint of someone who has had like a concussion or some kind of traumatic brain injury, and we are teaching them to kind of, there's nothing wrong with their eyes per se, but some of the wiring or some of the signals going to and from the eyes are, as a result of the brain injury, have gotten scrambled. And so it's a matter of rehabilitating or kind of rewiring or teaching techniques to kind of compensate or resolve that. Then there's another component of vision rehab that I think about, which deals with patients that have low vision. And so patients that have low vision, now what we're doing is not necessarily rewiring the eyes or doing anything like that, but we're using external devices to kind of bring back or improve some of the abilities that have been lost. Um, be it reading or be it mobility, things like that. So to me, that's kind of the what I think about when I think about that phrase.
I think that's a very good way you put it, Dr. Mojallal, is vision rehabilitation isn't entirely like saying I've had hip surgery and now I'm going to go for PT and get back to walking. If it's a traumatic issue, like Dr. Mojallal said, if you had a traumatic brain injury where there's nothing wrong with the eye itself, but it's how the brain now is perceiving the information coming from the eyes, then there are different strategies to overcome that issue. And eventually, hopefully, you overcome those problems that are occurring in the brain to deal with the brain injury and deal with what the eyes are perceiving. Our more typical and conventional low vision rehabilitation that we're doing in the offices with the prevention of blindness is people who have a bona fide condition in their eyes, like we talked about, macular degeneration, glaucoma, or diabetic retinopathy, or people have congenital conditions in their eyes. Um, and I know some of the people on the call have congenital conditions where they may have albinism, or they may have congenital nystagmus, they may have retinitis pigmentosa, but these are definitely things that are different in the eye itself that we're now helping you compensate for with tools and strategies. We're not going to say, despite those things, we're going to get you back to normal and 20/20 vision, as you would think of it, but we will use what you have and make sure that you can still manage your independence, safety, and quality of life. So that's what vision rehabilitation is all about. And it is a team approach. We work with the Low Vision Resource Center, but we also work with orientation and mobility specialists. These are like the physical therapists of people with eye problems. Physical therapists give you a cane because you physically need to hold on to something so you can walk better. And orientation and mobility specialists give you a cane, which is an extension of your hand. So you, because of your vision limitations, can sense with the cane what your eyes are not seeing, typically when you're walking. So we work with orientation and mobility specialists. We work with rehabilitation teachers. And many of you have had services through DOORS, the Division of Rehabilitation Services, or through DBVI, the Department for the Blind and Vision Impaired, or through RSA in DC, which is called Rehab Services Administration, where somebody comes to your home and helps you find accommodations, find things you can do to make it safer and more independent in the home. So all of this is a process, and we work as a team, if you like, and it's the whole process that eventually gets you to be more self-sufficient, more independent, and more capable of doing things on your own. So hopefully now you're having a better understanding of the low vision rehabilitation and what the process is. Through POB, our dream is, our goal is eventually to have more comprehensive services. You know, I've always imagined that one day we have a one place, one facility which has occupational therapists, rehabilitation teachers, and you come to this one location where you have the full team available to you, accessible to you. Now, some of this team is still best served to you in your own homes. So I talk about lighting, Dr. Mojallal talked about lighting, but you know, you're trying to implement the lighting in your homes or your places of work, or for children who are visually impaired in their schools. It's hard to do that in a clinic setting, much as we've created this building in DC, which has some of these things, but ideally you need to be able to implement it in your homes and places of work and so on and so forth. So we do need occupational therapists, rehabilitation teachers who come to you. And it's the same with the mobility things. It's not that I want to see how well you get around my office. I want to help you get around more safely and independently out in the real world. So the mobility specialists actually need to come to you and work with you one-on-one in your homes and everything. I see now we're approaching, you know, the last 10, 15 minutes. So I want to make sure we open it up to questions. And Dr. Mojallal, I see in the chat there are three questions. One is about research, one is about fluorescent lighting, and one is about peripheral vision. So let's do this. I think in terms of research for macular degeneration, you know, we'll need to have a retina specialist, and I'm sure Dr. Tara can arrange for a retina specialist one day to do these calls where they can talk about the new research to replace the shots we're getting. Between the fluorescent lighting and peripheral vision, you pick one, I'll pick one, Dr. Mojallal. You choose which one do you want to take?
Sure, I can do the fluorescent lighting.
Go ahead, you do that one first then.
Okay, let me just, I can't see the question on my screen.
The question is, fluorescent lights in grocery stores really bother my eyes. Is there a specific colored lens you would recommend I try?
So with fluorescent lighting, what's kind of worked for me in the clinical setting has been kind of more tints in the gray, gray zone. So that would probably be the place that I would start with. But we have to remember that one of the things with the fluorescent lighting is it's not so much the light itself, but also the cycling of the light, the cycling of the pattern with that flicker that it creates. And so the nice thing is a lot of these are changing to LEDs, but there's still quite a few places that have the fluorescent lightings. And I tend to start with the grays for those.
Mm-hmm. And Sue, for your question about what do you recommend to improve peripheral vision for patients with glaucoma? So improving peripheral vision in general, so is a real challenge because we can give you lenses to magnify and make things bigger, but to make you see out of the sides and out of the edges is actually quite tricky. Now, you will have heard of people saying, well, I've heard there are prisms, and prisms are lenses that shift images. Typically, we use prisms in, imagine a child who has a lazy eye where one eye turns outwards, and we want them to use two eyes together. We would use the prism to shift that image over to that lazy eye where that eye is looking. And that's typically the use of prisms. For people with visual field loss, there is a prism that's used in hemianopia. Hemianopia means you've lost so much peripheral vision, you basically have half of your visual field only. So you might be missing everything from the right or everything from the left. And we do use what's called a Fresnel prism. So it's like a sticky prism we attach to the glasses, and it creates awareness of that deficit. But the amount of improvement it gives is so small, it's not enough to go edge to edge. So somebody's saying, I want to get back to driving and I need my peripheral vision. It isn't good enough or effective enough to do that. Those kinds of Fresnel prisms that we use are good to create awareness that there's an object there, and then you still have to turn your head and look at it. So it's not that useful in a glaucoma peripheral vision loss. And you may have also heard of people with RP, retinitis pigmentosa, who have tunnel vision using a telescope reversed. So think of it this way. All of you have probably looked through your binoculars the wrong way, backwards, and everything looks small and far away. And sometimes for people with RP, a reverse telescope where they take a little pair of binoculars, a monocular telescope, hold it backwards, will give them the lay of the land, but they'll only use it briefly, and then they still have to navigate using their cane or whatever they're going to do. So the bottom line, Sue, is that for many of my patients who've lost peripheral vision with glaucoma, I am referring them for orientation and mobility training, and they're using the cane to compensate for that deficit of peripheral vision.
Sorry, Dr. Alibhai, I just want to make sure those who do not use chat, if they have any questions, if you could unmute yourselves, because it's hard for some people to use the chat option.
And Tara, here's a question for you in the chat. Do the POB resource centers have the vision loss simulators that sighted individuals can test to better understand what I experienced? That's Jillian saying, I'd like somebody else to recognize what I'm seeing.
Jillian, we have them. I've seen them in our DC office. Yes, we do. So if you want to bring someone who's sighted with you, we're happy to have them try them out.
So we're down to the last few minutes, and this time, instead of in the chat, if somebody has a question, they can just unmute themselves and ask your question. Wow, Dr. Mojallal, it's such a great job. Nobody has any questions.
Hello.
Go ahead, owner.
Oh, this is yeah, I'm not tech savvy, so I'm not sure why I'm coming up as owner. Apologies for that. But Dr. Alibhai, I just wanted to thank you for everything that you have done. I met you years ago finally, and just trying to navigate all of this, the work you've done, and now that you've joined with POB is great. So just wanted to thank you personally. This is Karen Akins. I think I've seen you a few times in Virginia. So thank you.
Thank you so much.
And
Karen.
welcome, Dr. Mojallal. I appreciate it.
Thank you.
Any last questions? We have 5 more minutes. Any last words of wisdom, Dr. Alibhai, Dr. Mojallal, before we adjourn?
Anything you want to say, Dr. Mojallal, or shall I?
I would just say that you know, if there's something that you can't do that you want to do, don't just give up on it, and you know, bring it to our attention. perhaps there is something, perhaps there isn't something, but you'll never know unless you ask. And I think that would be one of the things that would be one of the messages that I would want to kind of send home. In addition, just because there isn't something right now doesn't mean that there can't be something in the future. So, always have hope. This is a field that is growing and expanding, and the technology is changing every day.
Yeah, I would echo that, Dr. Mojallal. You put it beautifully. I think for anyone experiencing vision changes, it's emotionally a difficult process, and it's hard to accept that it's now so difficult to see things that were so easy to see, and we live in such a visual world that every people, even if you ask somebody for directions, they'll go, well, it's over there, take a look. Well, just look it up on your phone, or the expectations that everybody can see. And when you're visually impaired, it's not obvious. People would not automatically recognize that you're visually impaired, so it can be emotionally difficult, and even your family members can be trying to be helpful, but they don't quite get it either. So I appreciate what Jillian's saying, do you have simulators I can show somebody what it feels like? And even those simulators may not be a perfectly good simulation, because even two people with macular degeneration will see quite differently. But to again echo what Dr. Mojallal says is don't don't give up. Come in, ask for help, let's see what we can do, and let's work at it together. It's not that we have all the perfect solutions for everything. We actually do a lot of trial and error and experimenting ourselves, and by working together, hopefully we'll come up with some good solutions for you. I see Sandy Newsel has the last say here. Go for it, Sandy.
Hi, Dr. Alibhai.
Hey.
I was going to add that rehabilitation is, emotional and attitude and working with other people and working with your family so they understand. And you did a wonderful job of preempting my question and answering it. So, rehabilitation is the medical side, the physical side, and the emotional side.
Right. Yeah. No, thank you, Sandy. And Sandy runs a support group, and I really admire and appreciate all the people who are involved one way or the other, whether they're running support groups, whether they're doing the Low Vision Resource Center, or whether you, as you go back to your rooms and meet with other people, your friends, you're saying to them, hey, you know what? There's something that you could do for this. There's something available. Why don't you talk to so and so? Why don't you contact so and so? Why don't we go to this support group? Have you heard of Talking Books from the Library of Congress? It's important that you keep spreading that message out there, that there is hope. There are things available, and just try some of these things and see if they work out for you. All right, Tara, back to you.
Thank you very much, Dr. Alibhai, Dr. Mojallal. This was great. And for everyone, we are in it together. So please give us a call and we will help in any way we can. Thank you again, everyone, for joining us.
Thank you.
Okay, bye-bye.
Thank you. Bye-bye.